So today I'm going to talk about steering the future of medicine, a human-centered AI in the generative age. So AI today really can do so much, right? We use AI to assist physicians, as shown here in a few news media outlets. AI helping doctors to spot broken bones on X-rays, and AI helping cancer patients receive personalized and precision treatment faster, and AI models accurately identifying tumors and diseases in medical images. This is what the regular media reads. We as clinical informaticians tend to read the literature. But it is important to also keep an eye on what the general public knows about AI. So one of the questions that always come up is AI getting smarter than doctors? Regardless of my ambivalence on that question, there are articles now and studies that have shown that AI passed the US medical license exams, and many of them outperform US doctors in terms of the exams, which is quite interesting. And there are also articles showing that AI can detect prostate cancer better than physicians, as certain studies say. But then the question then, does AI capture the empathy that humans have? So that was an angle that I've always told people that, well, you know, AI is smart, AI can do a lot of things, but it doesn't really capture empathy. But then recently, articles like these pop up now, right? Google AI has better bedside manners than human doctors and made better diagnoses. Here on the right one, this study shows that AI chatbot provides quality and empathetic answers to patient questions. And recently, one of my colleagues actually from Boston Medical Center was telling me that they actually have a choice between AI and a doctor to talk to a patient during discharge at the hospital. And oftentimes patients prefer to talk to the AI, which is very surprising. So this is a study that was done at UMass Chan by one of our researchers. And I bring this up because AI now has the ability to detect, as you know, features and biomarkers that are undetectable by human beings normally, like voice. In this case, they incorporate a machine learning model to detect voice features that could significantly improve the performance of predicting future of risk of dementia. And this is another study also by the same Professor Lin at UMass Chan that uses EKGs to identify certain features now that can predict your cardiovascular age, your true age, from a biological perspective. So we're basically getting to a point where AI is able to detect things that even humans are not able to see. Here's another study by one of our gastroenterologists who has developed an AI model to diagnose biliary tract malignancy. And the sensitivity and specificity of his methodology is extremely accurate and has basically demonstrated such significance that he actually sold that technology to to a private company now. And recently, working with Hallym University, I was really amazed at the AI telemedicine platform for intracerebral hemorrhage that they've developed. They use it for rural doctors to consult specialists and improve outcomes in underserved areas. So we basically have shown today that AI is really here, right? I mean, there's no doubt about that. AI is really overtaking pretty much anything out there. It is the fashionable term of the year or the past couple of years now, as you can see. This is simply just a list of the number of manuscripts and publications that has happened in the past several years. Obviously, I collected this data probably early in 2025, so that's why the last bar is lower. But as you can see, it's really skyrocketing up. So the bottom line is that AI has really moved from curiosity to full clinical integration. This graph essentially shows the AI tools that are being approved by the FDA. And you can see that over 500 AI ML tools have cleared the FDA in 2023. And it's skyrocketing as well, reaching close to 1,000 by August of 2024. And now I imagine that surpassing even further. So over 75% of large US healthcare systems are now experimenting with generative AI. 90% of the radiologists expect AI to be part of the workflow within 3 years. So I did some research on South Korea as well. And it's clear that South Korea is a global leader in health AI. Interestingly, South Korea healthcare AI market is projected to grow at over 50% annually, reaching 2.1 billion by 2030, outpacing all global trends. The government's 5-year roadmap between 24 and 28 aims to double commercialization of healthcare AI and boost research and development in digital health and medical data systems. Korea enacted the world's first Digital Medical Products Act in 2024, providing clear regulatory pathways for AI-driven medical device and software. And some of the leading hospitals, that include Seoul National University, Bundang Hospital, and Severance Hospital, rank among the world's top 100 of AI adoption in clinical care and research in the world. But it's important to kind of understand this really rapid rise of AI is actually rising in the setting of a fractured system in the background, right? So in the background, our healthcare system today, costs have outpaced GDP for over 20 years, with 20% deemed to be wasteful. Over 50% of healthcare workers report burnout, and the WHO projects a 10 million health worker shortage by 2030, especially in the low to medium income countries. So AI offers transformative potential, but the problem is that it's entering a system that is under a lot of pressure, right? So on one side, we've got medicine, old industry that is highly regulated, extremely cautious. And on the other side, we've got AI that's dynamic and moving very quickly. There's a mismatch there. And that mismatch demands new strategies for trust and integration. So the question is, does the old work with the new effectively? So there's a mismatch of speed and safety as well. So as I said, right now, we have over 1,000 FDA approvals of AI models. And if you look at pharmaceutical industries today, it's about the time of development is 15 years per development. And whatever drug that gets developed is rarely updated, as opposed to in AI tools, development is in weeks or months and frequently updated. Pharmaceuticals have approved 47 FDA per year at 2.8 billion per drug, whereas AI, over 1,000 tools launch yearly, and many updated post-development on top of that. So I thought that this turtle with a rocket actually kind of illustrates that the condition that we are, where the turtle is the current healthcare system and the rocket is AI. The challenge is how to make them work together. So legacy evaluation frameworks, when designed for probabilistic evolving systems like large language models. Gen AI creates content dynamically, trained on tools that are too vast to fully understand properly. And AI requires really life cycle evaluation and post-market surveillance to ensure reliability over time. This is a study that I did actually over 15 years ago. And it's a lesson that I think still applies today, where we are really focused on high performance AI models and try to stretch as much as, try to bring the ROC curve as high as possible. And oftentimes what happens is that the rate limiting step of an application of an AI may not necessarily be the AI anymore. It's actually the clinical setting that you try to integrate the AI may not be able to perform at the level, right? So in this case, what we actually did is that we developed an AI model basically to identify patients that meet the criteria of heart failure, needing post-discharge care. And what we found is that the AI model starts identifying a lot more patients than were previously identified based on our gold standard. And it turns out that the patients that the AI started identifying were actually cases that were previously missed before the AI was implemented. So now we're identifying so many more patients that need those services, but the rate limiting step is the service within the healthcare system. So what we've done is that we start marrying other technologies such as operations management. How do we apply operations research to those patients and optimize the process? So sometimes, as I said, AI is not always the answer. Math and people are. Ubiquity does not equate usefulness or trustworthiness. Ubiquity just means that the availability of AI everywhere does not mean that the AI is actually useful and trustworthy. So external validation of a widely implemented proprietary sepsis prediction model in hospitalized patients. So this is an example of a very well-known study conducted by Dr. Wong and published in JAMA back in 2021 that basically shows the EPIC sepsis model. And EPIC is the electronic medical record that is used at many, many hospitals in the United States. So I'll say today, definitely over 60% of all hospitals uses the EPIC electronic health record system. And within that electronic health record system, they have developed a sepsis model that basically predicts which patients have sepsis or not. And that model was launched and expanded to several hundred hospitals across the United States. And this study found that in the study cohort of over close to 28,000 patients, undergoing over 38,000 hospitalization, that sepsis occurred only basically sepsis occurred in 7% of the hospitalization, and way more than the true number. And it turns out that the area under the curve when they did the study was only 0.63, which is substantially worse than the performance that the developer was reporting at 0.76 to 0.83. And this is one of the problems when you start expanding the models beyond the population that you study the model on. So the EPIC sepsis model has low sensitivity, failing to identify over 67% of patients with sepsis. So despite this low sensitivity, it generated alerts for 18% of hospitalization. So ending up creating a really large burden of alert fatigue for the clinicians. So the lesson here is that the ease of EHR integration and loose federal regulations that we have in the United States really facilitated the widespread adoption of such bad algorithms by hundreds of hospitals. Something to really watch out. So now we're going to talk a little bit about fairness. This was a study, an article that popped up a few years ago about a study finding racial bias in an algorithm developed by Optum. And the whole idea is to, Optum wanted to create an algorithm to identify which patients require additional healthcare services. And the problem was that they used an algorithm that ended up favoring white patients by linking health needs to healthcare spending. So by picking a proxy to who needs care, inaccurately end up worsening fairness. And the impact basically showed that the risk of bias in AI algorithms, especially when they affect care allocation. Another dimension to think about is security of all the systems that we use for AI. This was an article that popped up showing that Microsoft's own AI company leaked affected 1.2 million patients through a breach. And the data breach actually impacted patients that were at UMass Chan Medical School as well. We used this software, Move It, and basically ended up in a very difficult situation with PHI leaked out in the public space. Here's another study that is an interesting find. Apple Watch, as you know, have this great tool to detect atrial fibrillation. And this study was actually approved by the FDA for use for atrial fibrillation. But what Apple does not really advertise is that they were approved for adults older than age 22, and said that there should be cautionary use of this tool for patients under the age of 65. So it's really recommended for 65 and above. So the problem is that, when you release a tool like this, initially, a lot of patients, young and healthy, were coming into the hospital, into the emergency room, saying that they have atrial fibrillation because of their watch, causing, again, another outrageous waste of our resources. So the lesson learned here is that it is really important to test the AI across real-world environments and making sure that the population that you test this model is the one that you advertise to the public after. So this is an interesting news as well that appeared last year. The nurses from the California Nurse Association organized a protest in San Francisco aimed at Kaiser Permanente against AI. And the reason is because there were questions of safety and unreliability from the AI perspective. And also, there were also fear of job replacement. There were also fears of, the lack of transparency of these tools. So we are at the early onset right now in the AI revolution. And it's little news like this that I really worry about, because what happens if we scale AI at we can scale AI way more than what we have today. Is this the canary in the mine, kind of alerting us what would happen, right? So what is really important is that we make our AI obviously explainable, interpretable, but also that we educate and include everyone as we build these technologies. This is a perfect example of what happens when you deploy a black box AI system. You don't explain how it works. And there is a lot of reluctancy on the clinical staff to use it. So many of you probably have seen this, the Gartner bell curve of hype. And as you know, we went all the way up the hype of AI, and to the point we say AI does everything. And then there's a point now that we say we should be afraid of AI because of all these negative news that are popping up. And we kind of rode the bell curve all the way down. So we are now in what we call the trough of disillusion. This is actually a great place to be, because this is where we start working to get and build the true capacity and capabilities of AI. So I think we're really at an amazing point in time to actually collaborate and work on the future of this technology and how it could improve patient outcomes. So I believe there's a global imperative for trustworthy AI. Without international alignment, AI really cannot scale safely. The problem that I see right now is that different countries have taken AIs in slightly different directions. So the United States, especially right now in the current administration, is really emphasizing innovation, competitiveness, and remove a lot of the guardrails. So safety, fairness, a lot of these, they don't want to hear about. They want to just focus on just developing AIs. The European are emphasizing, on the other hand, a lot on safety and build a lot of multi-layered legislation. So the problem is that if you have so many safety protocols, you basically slow down innovation quite a bit. So, and then the global south in our planet, they actually lack resources for oversight of AI. So there is a divergence that hampers the AI scalability and public trust today. It is important to have global coordination for data, standards, and ethics. And those must cross borders. So looking at how South Korea leadership today in AI regulation, I really believe that South Korea actually plays a very important role in both regulation and adoption to offer a good, well-balanced model between regulation and innovation to the global model. So I think at this point, it's clear that we know that AI can do so much. So the question is really about guidance now. AI technical capabilities are accelerating, but capability alone is not the end goal. The question is no longer, can AI help, but how should we use the AI? The performance, high performance is not enough. We must ask, is it truly trustworthy? Is it truly useful? Is it equitable? Is it clinically meaningful? There are a lot of examples where really, really good performing AI models have been developed in the clinical setting with absolutely no impact on patient outcomes. And the reason is because when the folks that were developing the AI have not really done a deep analysis on the actual clinical workflow and realized that, guess what? The doctors were actually doing a marvelous job already. So the question is not about how good your AI is how much more can you provide what the clinical setting already has. So the future of medicine isn't shaped by the AI's potential, it's shaped by our choices. At UMass, we have built a collaboration with Halim University. We believe that an AI assurance lab is going to be essential in the future. We know that the efforts to do AI assurance is expensive, costly, and requires a lot of technical, multidisciplinary expertise to make that happen. So it does not make sense that every single AI developer would create their own AI assurance lab within on their own. It makes a lot more sense to start centralizing these assets. And we also believe that these assets should be done collaboratively, internationally, such as the one we're building now with Halim University. So the focus here is not simply just on building algorithms, but also identifying the guardrails and how to govern those properly. Our AI assurance lab at UMass follow the CHAI framework. So what CHAI stands for, it stands for the Coalition for Health AI. The Coalition for Health AI is an organization in the United States that encompasses over 3,800 members. That includes large academic medical centers, hospitals, public and private companies, and federal agencies as well. UMass Chan is one of the founding members, and I've shown there the logos of the 10 founding members of the Coalition for Health AI. Mostly it's famous, it's anchored on 5 large dimensions: usefulness, safety, fairness, transparency, and security. And we are working closely now with Halim because Korea has also identified key dimensions. And we believe that comparing notes and optimizing our AI assurance to work both in the United States as well as Korea makes a lot of sense. That means that AI developers in Korea can move their models in the United States as well as the United States moving the other way around as well. Another dimension about scaling trust is about public-private partnership. And why does this really matter? As we know, AI innovation is accelerating, driven largely by private sector. A lot of the AI technologies are developed in the private sector today, and academia tends to be pretty slow compared to private sectors. So we need to be able to keep pace with the development of AI that's happening within the private sector. So that's why we at UMass recently partnered with Red Cell Partners to create an AI assurance testbed for UMass Chan. So Red Cell Partners is a company based in Washington, D.C. that is essentially a VC for AI incubation. So they basically create many healthcare-related AI companies coming out. And then from there, the AI Assurance Lab will be testing these models for fairness, equity, and so on and so forth. So we don't think that public-private partnership is really optional. It's really the engine for us to scale ethical AI quickly. As I mentioned before, AI's dual impact, there is always a balance between its potential and its risk. So every time we build or implement AI, we always have to kind of have this in our head. All the potentials weighs against all the risk that comes with it. And our role as clinical informatician is to steer this. Do we want to steer a little bit to the left or right, right? Depends on how we do it. So AI is not a passive tool. It actively shapes care. Without intentional steering, it risks doing more harm than good. So these are just basically a few nuggets of mechanism that we are thinking about at UMass Chan on how to steer our ship better. One of the challenges that we have in the United States is human-centered AI. We do not necessarily always develop the AI guided by all the clinical values. We tend to be sometimes focused too much on the technical performance of the AI. We want to make sure that the AI is getting the absolute best performance without really thinking about where we actually implement this AI eventually. So it's really important that we develop tools that fit into the care environment. So the workflows, the team roles, and the real-world decisions. Good design really respect the clinical nuances and preserve the clinical judgment. So what I mean by that is that the clinical workflow, whether it's in the emergency room, in the ICU, the settings are very complicated. There are tons of decisions being made that have very fine nuances. And AI may not always pick those up. So we have to be very mindful of those when we develop these tools. It is important to keep in mind here, the lesson learned here is the model must adapt to the team and not the team to the model. So it is really important when developing these models that we develop it in the setting of the clinical environment that we aim to have the AI implemented into. And I've learned just recently that in Korea, you have less of that problem. In the US, we definitely have this issue of scientists being probably more siloed away from the clinicians. So co-designing is really the foundation of trust. So human-centered AI requires diverse voices at the design table. So at the very beginning, before you even come up with the AI, AI must be built with, not for the healthcare community, along with clinicians, patients, nurses, engineers, ethicists. We like to bring all these people together at the table when we even start planning and designing any type of technology. So we have seen that in ICU tools reshaped by nurse input has led to safer decisions and higher adoption. So the bottom line here is the accuracy builds confidence and collaboration builds trust. So human-centered AI requires proactive fairness. And this is something that probably more in the old school, I would say. In the early days when I developed AI, we developed AI in a silo, and we just simply just take EHR data and start developing our machine learning models. But as you know, bias can enter everywhere. You can have bias in your training data. You can have inconsistent annotation of features in your model. You can have exclusionary model architecture. And also you can deploy your model inequitably as well. And yeah, this is illustrated perfectly by that example I mentioned earlier on, by the model developed by Optum that favored white people versus Black. The key here is not to think about bias at the end when you deploy your model, because if you do it at the time, it will be too late. So fairness must be a design principle from the very beginning, and it cannot be an afterthought. So the second steering mechanism is the ethical assurance. And what I mean by that is that we have to govern how AI is used, not just how it performs. Earning its trust through explainability and oversight. And that's the example provided with the nurses. The ethical assurance is the value layer that guides how AI is interpreted and applied in care, not just how it's evaluated. So it's not just about performance, but the value. It works within and beyond AI assurance by shaping how humans use AI in ethically complex environment. We have to make sure that AI systems are explainable, consistent, and accountable. We know that model drift is a big problem, right? So consistency is difficult, and we need to have mechanism to keep verifying the models. But it's not just model drift, but this model shift. So even if you create a model at one organization, and oftentimes people say that, well, there's a different culture, so the model is probably different. The data, because the data is collected differently. But I've actually seen models developed using only an X-ray machine. So simply just taking an image, you think that there is no bias there, but there's actually bias and shift, meaning that a portable machine versus a non-portable machine actually has different data. And AI is actually able to recognize that and can actually look at severity based on whether it's portable or not, because it knows that if you're doing a portable X-ray, that the patient is not able to move. So you have to watch out for these kind of things. So AI can validate a model's accuracy, fairness, safety, security, and transparency. Ethical assurance decide whether, when, and how that model should be trusted in care. So measuring performance is necessary, but governing its use is really what ends up earning the trust of the model. So the ethical assurance really begins with data integrity, as I mentioned earlier. Without the data integrity, which is the foundation of trust, nothing else is going to work. So your foundation is built on trustworthy data, making sure that it's ethically sourced, accurate, and representative, that you have privacy preserving, as well as governed by very clear policies. It's also actually really important to have accountability so that you know throughout the entire life cycle of the AI development, who's responsible for what. And also during usage, there needs to be a plan B. When the AI is not performing as expected, how do you detect that? Who is accountable? Who is verifying it? Who is checking this? What are the policies in place to watch out? So again, without trustworthy data, even a powerful AI can be unsafe. All right, the third steering mechanism here is human AI collaboration. As we know, amplifying human insights is really, I think, what we should do as opposed to replacing it. The most effective AI augments clinical reasoning. It does not substitute it. And yeah, I'm not going to go through these examples, but AI sees statistical patterns. Humans apply ethical judgment, empathy, and nuance. It's really important to realize that AI and humans are not in competition. Oftentimes in publications, I do a lot of reviews, and I see that the conclusion is that, oh, AI beats the human, or AI is better than this. But it's not a competition. Our goal is not to beat the human. Our goal is actually to enhance the human and to make them work more effectively, more efficiently, and leverage what the human is strong at, right? So taking that approach, I find it a lot more productive than trying to always compete. Training is also really important. Training the entire team to partner with AI is important, right? So AI literature care teams are essential for safe, ethical integration. And education must evolve to include AI fundamentals and limitations, bias detection, critical thinking, and ethical reasoning. Well, nurses in particular are the frontline decision makers and workflow steward. They are the expert in the clinical workflow for every single care management you want to give to patients. If you don't include them, how are you going to be able to integrate any AI effectively? Just a thought. Human empathy, situational judgment, and relational care remain irreplaceable. So preparing for an AI future means that training, not just the physician, but the entire care team to question and challenge and guide the AI. On the right side here, I just put a quick graph. I kind of start thinking about all the different biases that traditional clinical research has. And now all the different types of biases that we now have to learn because of AI, right? Missingness bias, algorithm bias, proxy label bias, measurement bias, automation bias. There's so many things that we have to learn that we need to educate our clinical partners and care teams to really understand what to look for when AI goes wrong. Again, I believe in global collaboration. I think that really matters because we need diverse data sets, especially when it comes to fairness. We need shared governance. We need better AI models. We need AI models that we can share with each other and train and validate locally. So international partners are important to do all of that. And AI medicine at the end must reflect the diversity of the world that we serve. All right, so in summary, AI is a shared responsibility. What we need now, though, is ethical leadership. And clinical informatician must guide how AI is being used, not just simply build it. And we must include equity, safety, and collaboration in every step of the way. So data, design, and deployment. So I put that little graphic here, right? We clinical informaticians are the one building the bridge between technology and clinical care. So our shared responsibility is to make sure that AI fits real clinical practice, not just the technical goals. We need to use the technology to support, not replace human care. We need to build trust through clear, fair, and careful use of AI. The bottom line, the future of AI in medicine will be defined less by what it can do, but more by what we choose to do with it. So charting the course forward build with users, audit with rigor, and collaborate broadly. All right, so I'm out of time. I'm sorry. Thank you so much.